Hi, my name is Andrew Nevins. I'm with the Division of Infectious Diseases at Stanford University School of Medicine, and in this video I'll be talking about viral diagnostic tests, and in particular those for Epstein-Barr virus. The learning objectives for this video are to be able to interpret diagnostic tests for EBV and other viral infections, to understand the uses and limitations of the heterophile antibody, and to recognize the strengths and limitations of various viral diagnostic modalities. Before the advent of newer diagnostic techniques, in general, microbiologists relied on culturing a virus in the laboratory and looking for viral cytopathic effects, which are morphological changes in cells observed when they are infected in vitro. Different viruses produce different cytopathic effects. Examples of common viral cytopathic effects include rounding of an infected cell, the production of cytoplasmic inclusion bodies, and fusion with adjacent cells to form syncytia. However, the use of viral culture can be challenging because viruses including EBV can actually be difficult to culture, and this, along with looking for the cytopathic effects, ultimately takes a long time to perform. So, there are a number of other options available to diagnose viral infections, including Epstein-Barr virus. For EBV, these include the so-called heterophile antibody, serology, and polymerase chain reaction, or PCR. Recall that acute EBV infection leads to infection of B cells and subsequent B cell proliferation. It is this B cell activation and proliferation that leads to the development of the so-called heterophile antibody. Heterophile antibodies are antibodies induced by external antigens and can react to antigens across many different species. The so-called monospot test is a test for IgM antibodies with affinity for sheep and horse red blood cells. Response is generally within the first week and can persist for 3 to 6 months. Reactive heterophile antibodies in a patient with a compatible mononucleosis syndrome are diagnostic of a primary EBV infection and are therefore the diagnostic test of choice in most clinical settings. No further testing for EBV-specific antibodies is usually needed if there is a reactive heterophile antibody. Although they are very specific in the right clinical setting, heterophile antibodies are somewhat insensitive. In addition, its test characteristics vary by age. It is present in 80% of infected teens and adults, 40% of all infected children, and only 20% of infected children under 4 years old. Heterophile antibodies are not positive during the incubation period. The false negative rate, generally 10 to 15%, is usually highest during the beginning of clinical symptoms and falls to less than 5% by week 3. So for patients with a compatible syndrome, heterophile antibodies can be repeated if the first test was done early in the clinical illness. More specific EBV testing can be pursued for those with a more prolonged illness, or if you suspect an alternative diagnosis. Of course, it's important to remember that because only about 20% of infected children under 4 years old can produce the heterophile antibody, the false negative rate is quite high in this patient population. Heterophile antibodies can arise in non-EBV infections too. False negative monospot tests may occur, for example, in cases of HIV, lymphoma, or lupus. As we learned earlier, the mononucleosis syndrome can be due to many other infectious and non-infectious etiologies, so a heterophile antibody test will not always be positive. If this is the case, searching for an alternative etiology will be important to pursue. It is also possible to use serology, or the detection of antibodies to viral pathogens in the serum, including EBV. Assays for many, if not most, viral pathogens rely on the detection of IgM and/or IgG antibodies. IgM refers to those antibodies that are produced immediately after an exposure to the pathogen, while IgG are produced later on and refers to a past exposure, a longer-term response that usually persists, but not necessarily active infection. Serologic detection of most viruses relies on the measurement of IgM and IgG antibodies, usually using an enzyme-linked immunosorbent assay, or ELISA. It is very important to think about the patient's clinical presentation during the interpretation of these assays. This is especially important for herpes virus infections, as there may be an acute exposure with or without symptoms, evidence of prior exposure, and/or reactivation disease. Let's look at CMV as an example. If both IgM and IgG are negative, then there is no serologic evidence of current or prior infection, so chances are that symptoms that a patient is having are due to another cause. Keep in mind, though, that antibodies may not be detectable because they are unable to be produced, for example, in patients with some types of immunosuppressive disorders, including B-cell deficiencies. A positive IgM with a negative IgG is usually indicative of a recent active primary infection. However, the production of IgG antibodies may naturally decrease over time. However, the production of IgG antibodies may naturally decrease over time, so that this result is not necessarily diagnostic of an acute infection. It may also indicate that someone has been re-exposed to CMV or that there is reactivation of latent CMV if antibody production has in fact waned. A negative IgM with a positive IgG typically indicates a past exposure and that the person is immune from primary infection. In the setting of a herpes virus such as CMV, of course, there is the possibility of latent infection and may therefore be at risk for reactivation disease if there is subsequent immune suppression. If both IgM and IgG are positive, there is usually one of two possibilities. For many viral infections, it usually indicates that there is an ongoing active primary infection in which IgM antibodies continue to be produced, even though For many viral infections, it usually indicates that there is an ongoing active primary infection in which IgM antibodies continue to be produced, even though the body is able to generate an IgG response as well. For a herpes virus such as CMV, however, reactivation of latent infection can also account for this pattern. So there's a lot to think about when ordering and interpreting viral serologies. Furthermore, these tests can be positive, negative, or at times equivocal, meaning that the antibody test did not produce a clear positive or negative result. Checking again or utilizing another diagnostic test may be needed in this circumstance. In addition, remember that any diagnostic test has both a false positive and a false negative rate. For example, some tests may be negative because the assay was checked during the incubation period of a virus, and the body has not had enough time to generate IgM antibodies. These antibody tests also rely on the immune status of the host to actually mount an antibody response. Now, it gets more complicated for Epstein-Barr virus serologies because there are actually several types of immunoglobulins that are detectable for EBV. In prior videos in this module, we had talked about some of the different gene products that are produced, and these are important when interpreting an EBV serology. The viral capsid antigen is produced as a late lytic gene product and helps to form the viral capsid. Antibodies to the viral capsid are present during clinical illness and are both very sensitive and specific. Antibodies to the viral capsid are present during clinical illness and are both very sensitive and specific. The IgM antibodies appear first and tend to disappear after a few months. IgG antibodies tend to appear after about 4 weeks later, but then persist. Although it may not be detectable in all patients, IgG against the early antigen, another lytic gene product, appears early in clinical illness and disappears after symptom recovery. It may then also be produced in the setting of reactivation. The presence of antibody to the early antigen indicates that EBV is actively replicating. The ELISA tests that detect antibodies to the EBV viral capsid antigen and early antigen are more sensitive than the heterophile antibody tests. Lastly, there are many Epstein-Barr nuclear antigens which are produced during latent EBV infection. These are expressed when the virus starts to establish latency, typically 6 to 12 weeks after initial exposure, and can persist indefinitely. Examples of some test results are provided here in table form. Although EBV serologies can be challenging to interpret, remembering that different viral gene products are produced during lytic and latent stages of infection can be helpful. Interpretation of these serologies will also, of course, depend on the clinical and immune status of the patient. Lastly, polymerase chain reaction, or PCR, involves the amplification of a small segment of DNA. A qualitative PCR detects the presence or absence of EBV DNA in a particular sample, whereas a quantitative PCR detects the amount of virus present in the sample. A qualitative PCR detects the presence or absence of EBV DNA in a particular sample, whereas a quantitative PCR detects the amount of virus present in the sample, a so-called viral load. As PCR is expensive to perform and may not ultimately result in a change in therapeutic management, there is ongoing debate about the most appropriate use of the PCR test. It tends to be used primarily for diagnostic purposes in immunocompromised patients. There are many viral diagnostic studies from which to choose. Appropriate interpretation of these studies relies on an understanding of the biology of the virus, diagnostic test characteristics, and the clinical and immune status of the patient.